I will be advancing for you.
Okay, so I have no disclosure. Okay, and apologies, I'm just figuring out it's moving along a little fast. And I do have to state that disclaimers that all the views are my own and not those of my institutions, and I'm not being speaking on behalf of my institutions. And let's okay, so it seems like I need to say next. Okay, so here's the outline of my talk. It's going to be about immunizations, COVID-19 immunization in children. And of course, if we talk about children, we do have to talk about pregnant and lactating women as well. And so I'm gonna try to briefly review the burden of COVID-19 in children, as well as the immunization in this population, and do the same in pregnant and lactating women. Next slide. And so, this table depicts the clinical manifestations. I think previous speakers have gone over the epidemiology and the etiology of COVID-19, and so no need to repeat it. But as you all know, children experience mostly asymptomatic or mildly symptomatic SARS-CoV-2 infection, manifested mostly in constitutional or GI or respiratory symptoms. And some of those are listed in the table on your right. And as you know, they are non-specific and overlap with the viral infection. Next slide. Though there are some severe manifestations and sort of really well reported in the media, the AMHE-CEC, multisystem inflammatory syndrome in children, as called in the US a different name beyond the Atlantic. And there's been some surveillance definitions from the CDC as well as the World Health Organization, which also are on that table. In the interest of time, I'm not going to dwell on those, but suffice it to say that both of the citizens who call for either age less 21 or 0 to 19 has to be fever, no alternative plausible diagnosis in the CDC definitions, case definitions, some evidence, current or recent evidence of SARS-CoV-2 infection, and I should have mentioned as well, in addition to the fever, not only the fever, laboratory evidence of inflammation, and at least 2 organs involvement. And it's not the identical definitions in the WHO, but again, it's the same principle with fever, evidence of some clinical evidence, and as well as evidence of marker of inflammation, and some evidence of current and past or recent or past SARS-CoV-2 infection. Next slide. And so here's the burden of disease in numbers, and these are numbers from very recently, so as of last week, and these are from the AAP, American Academy of Pediatrics, has a nice website that they update weekly, and the link is at the bottom of the slide, and where those we can get all those numbers as well as nice graphs, and I will show you some of them. But in terms of numbers, it's the case was attributed for 4 million in the US as of last week, about 14% of all cases in US, 5,043 per 100,000 children, low rate of hospitalization consistent with the mild presentation of in children, so 0.1 to 1.9% of all children, cases in children, and 1 to 3.6% of all hospitalizations, and even lower number for death, so 0 to 0.3% of all cases. And there's quite a number of the AMHE-CEC cases reported. Looks a lot, but again, it's a really small fraction of the total cases of children in reported. And we have to know that it's vastly underestimated for a number of reasons, asymptomatic infection, etc. Some of them are listed on the slide. Next slide. And some graphical depiction of the cases in children and how they have been evolving over the course of this pandemic in adult. But again, it's usually 14% of the total burden of COVID-19. Next slide. And hospitalization rate, although low, as we just saw, but they still outweigh, exceed what we have for other viral disease, particularly influenza. And you can see the hospitalization rate over the surveillance week for COVID-19 in children for 2020 and 2021, and how it compares to influenza-related hospitalization in the previous year. Next slide. And as an adult, there also are underlying medical conditions that constitute risk factors for severe hospitalization or severe illness, or otherwise severe outcome for COVID-19. And this is a study, and I studied recently that looked at a large cohort trying to discern what are sort of those risk factors. And what we see emerging is that whether hospitalization or whether severe illness when hospitalized, we see that the most common are type 1 diabetes, obesity, cardiac and circulatory congenital abnormalities, and epilepsy or conversions. And either the other is maybe not identical for both severe outcomes, but you see the top 4. Next slide. Oh, someone asked me to speak a little louder. Okay, maybe it's my microphone. Let me try to increase it. So deaths, again, also as rare, but they do exceed deaths from other viral, other vaccine presentable disease, and even in the pre-vaccine era. Next slide. And we just mentioned about MIC, and so looking at the risk factors for MIC, we can see that there's some demographic risk factors on the top, and hopefully you can see my pointer. As you can see, the older adolescents, so 13 to 20, for either ICU admission or decreased cardiac functions, as you know, a severe complication for MIC. And when those patients were admitted to the ICU, and what factors that emerged are mainly laboratory factors, whether it's ICU admission, whether it's decreased cardiac functions, some factors such as fibrinogen, D-dimer, troponin, brain natriuretic peptides, C-reactive protein, and all those predict ICU admissions or decreased cardiac functions for children who have severe MIC. Next slide. And switching to vaccines now, as you know, these are the vaccines which are in clinical testing. So the RNA vaccines, the BioNTech, Pfizer, Moderna, the Novavax vaccine as a recombinant protein, the Janssen vaccine as a vectored adenovirus vectored Ad26, or the AstraZeneca as another vectored vaccine, the chimp adeno vaccine. So what's going on in adolescents, and we're going to see explain a little bit in the subsequent slides. So adolescents usually, so as we know, the Pfizer went down to 16 years in the initial testing. The dose used was 30 microgram and IM twice daily, 21 days. When they went down to adolescent, they still use the same dose, but using a dose escalation in younger children, and we'll see we'll see that in more details. mRNA using higher microgram dose, but same dose also is being used in their trials into 12 to 17. but using a dose de-escalation in children younger than 12. And the other Novavax Janssen also are planning or having ongoing trials. We will have to note that the trial had been paused in adolescent for the Janssen as well as AstraZeneca as of June 2021. Next slide. And as mentioned, the dose escalation, so the age escalation and dose escalation studied in children those less than 12. And so there's been two age group, the 6 to less than 12 years old, the 2 to less than 6 years old, and infant less than 2 years old. And the age escalation has gone from the first group, the older children group, to the middle children group, to the younger. And in terms of dose escalations, they started with half dose and have an interim analysis, move to full dose. And after an interim analysis, verifying the safety of the full dose in children that's 6 to 12 years old, then the cohort, the younger cohort, 2 to 6 years old, has been open, again, starting with half dose, full dose, and then moving on to less than 2 years old. And then after all these three age strata have, after vaccine safety has been observed in all those three age strata, then they observe the blinded part of the trial has opened. Next slide. And so in the Pfizer trial ongoing, 6 months to less than 12 years old, will plan to enroll 4,500 participants, several countries. Doses to be tested are 1/3, 2/3, and the full dose, and for the youngest children, 1/10 of the dose, 3 micrograms. The 3 microgram will be for children less than 5 years of age. And so hopefully very soon we should get data for the 5 to 11 years old, as well as the 6 to 2 years old. Those are going quite fast. The Moderna also will, similar number, almost 7,000 US and Canada, same as I mentioned, those finding, and randomized clinical trial expansion, moving from a quarter dose to half dose to full dose of their candidate vaccine. Next line. We know the Pfizer vaccine has recently received approval 12 to 15 years old in the US with the same dose as the vaccine, 30 microgram, vaccine efficacy of 100 milligrams, 100%. And the antibodies was non-inferior, actually seemed to be superior. And then we're gonna see some of those in graphs. Next slide. And the Moderna's phase 2/3 in 12 to 7-year-old also has enrolled a lot of participants. They also using the full dose, as I mentioned earlier. And they met their primary immunogenicity endpoint. Next slide. And some, also, briefly mentioning the Novavax vaccine, which was we plan to enroll up to 3,000 participants aged 12 to 17 years, mostly in the US, and to those 21 days apart and blinded crossover. And the safety outcomes to be observed up to 2 years. I'm not aware of any plan to go below 2 years. Next slide. I think we missed one. Okay, so yeah, so very briefly for the 12 to 17 years, and that's the Pfizer BioNTech vaccine. And those was from the CIP meeting where they were presented. And the pretty safe vaccine reaction were mostly mild injection site reaction. And this compared the 12, 15 years old to the 6 to 25 years old who were immunized in the first batch. And so it's similar safety profile in both age group. And on the lower graph on the right, these are mostly systemic events after those two. And without going into the details of the graph, but whether it's a fever, fatigue, headache, chills, vomiting, diarrhea, you can see that it's performed similarly in 12 to 15 years as to the older group, which was immunized alongside others. Next slide. And this is interestingly, the response has been certainly excellent in children. We know that children tend to mount better immune responses. Children and adolescents tend to mount better immune responses than adults. And we can see this and that seems to apply in the vaccine context. If we go to the next slide, we can look at the number in details. Next slide. And so these are the SARS-CoV-2 neutralization assay titers, 12 to 15 years. What the statistical analysis was a non-inferiority. And so it largely met that non-inferiority. And in fact, it was almost double the titers that you saw in 16 to 25 years. Next slide. And with regard to efficacy event against COVID-19, there was no COVID-19 infection noted, as opposed to 16 or 18 based on the population that you are looking at in the placebo group, and so vaccine efficacy of about 95%. Next slide. And so what's the rollout of COVID-19 in a vaccine in US in children? So these are all children under 18. These are not age disaggregated. So as of last week, again, AAP analysis of the CDC data, and these are publicly available data. 9.2 million COVID-19 vaccine, COVID-19 dose, and 7.1 million children have been fully vaccinated. Next slide. And looking at the cumulative number week over week, and those that have received, we can see a graphical depiction of those who have received at least one dose or have been fully vaccinated by age range 16 to 17, 12 to 15, and 0 to 11. And what we see is mostly, obviously, as expected, it's been a majority of age 16 to 19, and that's expected for a vaccine. But there's a reasonable good vaccine uptake, and obviously 0 to 11 are waiting data from those ongoing clinical study before there can be a full vaccine rollout. Next slide. And we need to mention also the events of myocarditis, pericarditis that have been noted mostly after the COVID-19 mRNA vaccines, and mostly from cohort study and review of surveillance structures that the CDC has, such as the VAERS or the VSD. And overall, what we see is that those tend to occur in the sort of first 21 days after. I mean, these are still rare events. They still occur in the first 21 days after, mostly after the second vaccine. There's a significant male predominance, but the course is generally benign with a full recovery expected. and the CDC and ACIP and AAP and other influential body have assessed that the benefits of vaccine continue to outweigh the risk in that pediatric population. And some of the graphs show you some of the numbers. Again, you can see that after dose 2 on the top right and on the top right graph, after dose 2 from BSD data, the per million dose about 12 close to 13 cases per million dose, but those were mostly in male. If you have somewhere 4.7 per million in females, but about 32 per million dose in males. So they're mostly vaccine associated, but still rare. Next slide. And as I mentioned, we have to also discuss briefly pregnancy and COVID-19, since as you could see, the immunizations went down mostly to 6 months. The plan for immunization went down mostly to 6 months of age. And the expectation is that children will be covered by maternal antibodies, which can persist up to 6 months. And so what do we see in pregnancy in terms of burden? So we know, and many publications from the MMWR and other have shown that an increased risk for perinatal complications, ICU admissions, and ventilations, mechanical ventilations, use of ECMO, even maternal death, and as well as pregnancy outcomes, such as stillbirth and preterm birth, when for COVID-19 infection occurring during pregnancy. Next slide. But even though there is, I'm not aware of any ongoing trial of COVID-19 immunization in pregnancy, although a lot of societies or OBGYN society have called for their COVID-19 vaccine are being administered and data are being collected. And what we see is sort of a robust increase in maternal IgG, and these are from cohort data. We see a robust increase in maternal IgG immune response, and usually this tests again the spike S1, S2, and the receptor binding domain. And there's also an adequate transplacental transfer of the fetus. And we see the titers in the neonatal bloodstream is substantial within 14 days of the first vaccine. We don't see any evidence of fetal IgM response to any of the vaccines, which is good. So so most of what is there is what's been transferred from the mother, and the transplacental transfer ratio. So cord blood or neonatal blood to mother's blood. What we see is that the increase with the longer, the farther away from infection or vaccination and delivery, then the more and the higher the titers in the newborn. Next slide. So some of those cohorts have also looked at safety in women who received COVID-19 vaccine, pregnant person receiving COVID-19, and they have not found any difference between the local and systemic reactions reported, and in the VSAFE surveillance system that the CDC holds. And there has not, compared to non-pregnant adults, there has not been any significant difference in terms of vaccine. One publication has not been maybe increased fever, but otherwise, no significant change. And when we look at some adverse pregnancy and birth outcomes, such as pregnancy loss and neonatal outcomes, Also based on the published incidence of those adverse outcomes in the general populations. When looking at pregnant women who received COVID-19 vaccine, been no increase in those outcomes. Now, these are relatively small numbers, and more being collected, but so far so good, no signal is emerging. Next slide. And also, there are data on the CDC website about the vaccine coverage. Now, these are the publication as of May. And so as of May, it's about 16% of pregnant women were vaccinated. And so it was a low number for what it was at that time. And as what we see in the non-pregnant general population, we also see a breakdown, and it's broken down by age and by race. What we see is younger age was a predictor of lower vaccination coverage, as well as race, and particularly Black and Hispanic race, a predictor of lower vaccine coverage, with Asian and race and others, particularly white race, also predicting higher vaccine coverage. So again, we see some of those same health disparities in vaccine coverage in pregnant women as in the general population. Next slide. Next slide. And so another slide in terms looking at the vaccination induced by SARS-CoV-2 in the immunization titers induced by SARS-CoV-2 in pregnant women. And what we see that these are robust. And trying to orient you to the figure, figure depicts either IgG to the spike or receptor binding protein, or IgA or spike or receptor binding titers. And the so what we can, and the V1, V0, V1, V2 are the so the time point. So the first time point before immunization, V1 being at the time of the second dose, and V2 at the time 2 to 6 weeks after the second dose. And what we can see is that those titers increased markedly, whether it's IgG or IgA, and whether it's for and they are similar to non-pregnant, for whether for women who receive either the Pfizer vaccine in open circle or the mRNA vaccine in the colored circles. Next slide. And those transfer to breast milk and umbilical cord. And I'm just realizing this is not the correct graph, so you're gonna have to take my word for it. But there is a strong transplacental and transfer, as well as transfer to breast milk. Next slide. And so this is a nice graph from the publications while reviewing the literature for this talk, which I like, and so I put it in the slide. And it depicts some of the somewhat of what we mentioned, but mostly on the increase of obstetrical outcomes related to SARS-CoV-2 infection in pregnant women, the generally so far promising profile of vaccination in pregnancy, as well as on the pregnancy itself, as we mentioned, increased neonatal outcomes. And one thing that I did not mention but should have is the question that come up always is, okay, well, is it transmitted? What's the vertical transmission from mother to neonate? And as you can see, so 3.2% is what's cited as vertical transmission, and that's also from CDC collected data. But again, we have to differentiate between perinatal transmission, from, for instance, an infected mother who can transmit blood droplets to their newborn at delivery. And those are usually mothers which have been infected in the last week or two prior to delivery with in utero transmission, which means transplacental infection, which is transmitted to the baby in utero. And there have been some documented cases, but these have been quite rare. Next slide. And so, to conclude, we have had, there are progress in pediatric vaccine clinical trials, and we're hoping to have quickly the Zika in the younger age group. There have been some ethical discussions about whether children need and should be given the vaccine, as well as whether in high-income countries, rather than vaccinating the children, those should go to adult at-risk in low-income country. But that's beside our topic. But as for adult vaccine, we're going to need to be mindful about the changing epidemiology, particularly the new variants that come now and may come later. There's hopefully strong surveillance systems, and I think part of the future plan for the future is to be administered to as part of the immunization schedule, and adding, even this on the slide, that vaccinations profile so far from observational study look very promising in pregnant women, and hopefully there can be an uptake of the vaccination in these populations, as these antibodies transferred to the fetus can last up to 6 months. And as there's no plan so far, as far as I'm aware, of clinical trial to less than 6 months, then they would rely mostly on transplacental transfer antibody to be protected. And so hopefully this is in the near future. And I think this concludes my talk. Next slide. And just want to acknowledge all the colleagues who contributed slides or reference papers as of that talk. And with that, I'll stop and be ready for questions.
Thank you, Dr. Jean-Philippe, for your excellent presentation. Now it's time for questions. If you have questions for the panelists, Dr. Jean-Philippe, Dr. Angelo Gus, Dr. Marjorie Jolicoeur, and Dr. Louis-Joseph Auguste. Okay, you can write your question on the chat also. Avez-vous des questions pour les panélistes?
Do you have any question for the panelists?
Et Dr. Jérôme, je vous laisse conclure s'il n'y a pas de questions.
Au moins, je pourrais...
Ou poser les questions vous-même.
Je pense que je pourrais demander une toute petite question au docteur Gus.
Oui, bien sûr, je suis disponible.
Le PSC n'a plus de valeur maintenant, c'est ce qu'on veut dire.
Non, je ne pense pas que ma présentation avait indiqué que le PSA n'a plus de valeur. Au contraire. Donc, je voulais mettre l'emphase sur la valeur du PSA parce que le PSA non seulement nous permet de dépister le cancer, mais après le traitement nous permet de suivre la probabilité de récurrence. Ensuite, le niveau de PSA nous permet de prévoir quels sont les patients qui sont à risque de progression ou bien de métastase. Donc, je pense qu'à mon avis personnel et comme médecin, comme urologue, je pense que le PSA a une valeur extraordinaire D'ailleurs, il n'y a rien jusqu'à présent qui nous permet de remplacer le PSA. Il n'y a pas d'autres tests qui ont vraiment, comment dirais-je, l'apport clinique que le PSA. Donc ça, c'est mon avis là-dessus. Hein.
C'est fondamental, c'est essentiel.
Je pense que le PSA est essentiel jusqu'à présent. Bon, c'est-à-dire que ce n'est pas un test qui est parfait, mais où réside la perfection de la médecine? Presque jamais. Il y a toujours des troubles, il y a toujours des incertitudes dans la médecine, bien sûr. Donc, c'est la même chose avec le PSA. Donc, il faut savoir s'en servir de ce test. Il faut la connaissance, l'expérience pour savoir qu'est-ce que veut dire le niveau de PSA. Donc, cela se comprend. Comme je l'ai déjà dit, ce n'est pas un test parfait, mais je pense qu'il y a beaucoup d'apports cliniques avec le PSA.
Can I ask a question on the same topic? I think the misunderstanding with the PSA in the past, it used to be used as a screening tool. And then there was a lot of confusion when they say screening for prostate cancer should not be, would start with the PSA. Could you comment on that? Maybe that clarify the confusion about the use of the PSA as a screening tool for prostate cancer.
Well, yes. The criticism has been a lot on the screening ability of prostate cancer, and part of it is the relatively high false positive rate. So you have many patients with elevated PSA who actually do not have prostate cancer, and many of these patients, because of the positivity of the prostate cancer, are submitted to prostate biopsy. Now there is some small morbidity to prostate biopsy itself, in addition to the course, this is understood, but none of the morbidities are usually lethal, but that's besides the point. So many patients were being biopsied. Many patients were being biopsied perhaps unnecessarily. And that prompted one of the United States Task Force to make a statement that was kind of against routine usage of PSA in medical practice. But it's very important to remember that the American Urologic Association, which is made our body of experienced people who see prostate cancer, BPH days in, day out, did not necessarily agree with that statement from the United States Task Force. In addition, the American Cancer Society did not really support that statement because we see the value of PSA. So the United States Task Force did that. The AUA did not necessarily support it. What we do know that the morbidity and the mortality from prostate cancer has significantly decreased as a result of PSA testing, because we are diagnosing currently prostate cancer at a much earlier stage. A clinically localized prostate cancer is much easier to cure. For all practical purposes, there's no cure for advanced stage or metastatic prostate cancer. So now we're able to have some men, we can tell them, you've been PSA free for 5 to 10 years, you will never die of prostate cancer. You will die of something else, but not of prostate cancer. So in the past, we didn't have that many men that we can say that to. And as we have improved technology with robotic prostatectomy and radiation treatment, we have decreased the morbidity of the treatments for localized prostate cancer. So the patients has actually done well, which I think is a great contribution to medicine.
But Dr. Goose,
can I say something? I would like to add a comment on Dr. Goose.
Yes.
That I agree totally with. This is the point of view of a radiation oncologist. We have to be careful with PSA, okay? People are looking at PSA and making, a witch hunt about this test. They are looking at it at the very beginning, they are looking at it at the common screening.
Right.
But as a radiation oncologist, and I agree with you what you said, we have to be very careful because sometimes, the worst tumors are the one with the low PSAs. We've been seeing an increase because we don't see those patients that you are talking about. We see the patients which have a biopsy-proven cancer. So we've been seeing a lot more of high-risk prostate cancer What I mean is tumor in the prostate, Gleason 9 to 10, with a very low PSA. Some of these tumors are associated with neuroendocrine tumors. So I think if you are going to do screening and you are going to take the PSA, the first time, okay, it's cautionary to say that, it's nothing, but you have to follow your patient and you have to do the exam. And if you are, I will say, a medical family doctor, maybe you should refer the patient to a urologist or radiation oncologist if you are not at ease with what's going on. So, and those patients, usually they are very young. And like Dr. Go said, whenever you leave the prostate cancer progress too far, that's when you're going to lose the battle, because there is no way back from, very aggressive disease with local invasion or metastatic disease. And we have to be very careful before we cast a stone on PSA.
I'm not going to cast a stone. I'm going to go back to screening. I mean, no one would give an argument if you have prostate cancer, PSA may be useful in determining whether you have recurrence of your disease or not. But we need to understand the confusion about screening. Screening for any cancer has its own problem in itself. The misunderstanding of the result, and then the confusion about the PSA arises from the fact there were conflict of interest. I understand where the USPS task force come from. There was a lot of criticism where the Urological Society has conflict of interest. So I'm not here to cast a stone on any one of them, but at least as physicians, we need to understand when there are confusion. If we ourselves are confused about the screening tool, think about the poor patient who has no clue what we are talking about. For this, that's why I asked the question. I wasn't casting any stone on the PSA itself, but I think it needs to understand there are a lot of confusion about it. And then that's what needs to be clear, especially for patients. I mean, when patients are confused, it defeats the whole purpose of screening.
Right. All these are very good points. And I think that I agree with Dr. Jolicoeur as well. And many of you, all of you who have made comments about the screening. It's very difficult in any cancer screening because you have a population that's asymptomatic. Everybody's coming over and you try to find out who has cancer, who doesn't have cancer. It's not an easy task, which is why I think Dr. Jolicoeur put an emphasis on a point that for the sake of time, I didn't emphasize. And I did show the slide. I did talk about it. I did talk about the digital rectal examination. A lot of people are dismissing the digital rectal examination. And Dr. Jolicoeur made a point. There are some patients that have normal PSA and have extremely aggressive prostate cancer. And many of them, if not most of them, the way we detect them is on digital rectal examination. And the reason is, it's because the cancers are so poorly differentiated that they do not have the machinery to even synthesize PSA, because synthesizes a lysine protease. So that enzyme, which is really designed normally to lyse the ejaculate volume, that's why PSA exists. But that, when the prostate cancer cells are so poorly differentiated, they are unable to make PSA, yet a lot of PSA, therefore you don't see a lot in the blood, but yet you have aggressive cancer. However, if you were to do a digital rectal examination, you would detect a hard, firm, nodular prostate with advanced disease. It happens all the time. So please, I do not advise people. I know it's modern time, patients don't like it, et cetera, but the digital rectal examination is actually very important.
A challenging question to Dr. Auguste. Dr. Auguste, do you feel that holistic medicine has some type of value in the treatment of colorectal cancer?
Well, I think as a way to support the patient morally going, because the treatment is pretty drastic, I think if it's going to give the person fortitude to go through the treatment, I think that's welcome. However, as a way to replace the standard approach of surgery, chemotherapy, and radiation, I don't recommend at all, because the person sometimes wants to try something recommended by friends or by relatives, and then and after 3 months, they realize that the treatment has failed. At that time, you basically have burned your bridges, and the prognosis has. I mean, we saw, what Dr. Jolicoeur showed, that every month of delay in therapy leads to further reduction in the survival possibilities. So definitely, I wouldn't recommend that at all, solely as maybe as a way for if that's going to give the person more endurance, more resilience. I'm fine with it, but instead of the traditional treatment, definitely not.
Can I add something? I would like I don't remember the name of the person who asked the question. I would like that person to define holistic medicine for me, please.
Dr. Jerome.
Dr. Jerome asked the question.
Dr. Jerome, actually, I cannot even answer your question, because I don't really, like Dr. August just said. I asked that question because somebody mentioned holistic medicine, in the beginning of the.
Okay, so what I will say.
Your opinion about this, that's all.
No, what I will say, it's depending on what you account as holistic medicine. In my point of view, my patients in the department that I put on are having holistic medicine, because they all have access to a psychologist, they all have access to exercise, they all have access to a nurse which knows about plants or whatever. But they only have access to that because they come to a radiation oncology department and because they're going to have treatment. So they're going to have a treatment which is soundly scientific based, and it is soundly also scientific based to help them cope with the diagnosis, with the psychologist, nutritionist, and even someone which can talk to them about all the things that we don't learn at school, and all the pills what they are selling in the pharmacy, which are herbs and things like that. So that's holistic medicine. But I think for me, it is holistic medicine. I think what people are taking for holistic medicine, it's the first step is to avoid the regular medicine that we know. That means surgery and chemo and radiation, and then to go with something else that is beyond comprehension to me. So I just want to say, because sometimes the patients are confused about what they want. In my patients, most of the time, if I just suggest the psychologist, and they are a little bit afraid to say yes, because they think that I'm going to just leave them and not take care of them. So maybe for me, holistic means taking care of everything. So the mind and the body, and we even have I don't know how to say that in English, a counselor for to pray with them if they want. That for me is holistic medicine.
A chaplain.
A chaplain. Actually, this is exactly what I had in mind, because there was a patient that I think myself and Dr. Auguste, we shared together. And then the family decided to say, they say because of the church, and then they wanted holistic medicine, changing the way they eat, something like that, receive medication like herbs, and trying to see if they can slow down the process before they go back to the surgeon. So that's this is a question that I was surprised to that approach, because the person is a physician, but this is real. It's happened. So I wanted to have your opinion about it. And that the reason I posed the question.
I think you have to do all of this if you want, but not before you go for surgery, for instance, okay? Because, you know, the primary thing is you have to follow whatever is published. And in published things, you know, you have surgery, radiation, chemo, and with, you know, results on outcomes. And yeah, psychology also have their results on outcomes. But, you know, all this has to be done together for me, in my opinion.
Well, I think often the patient confuse prevention and treatment.
Yeah.
Certainly, there is some indication that diet, you know, might be a factor in preventing cancer, and calcium, aspirin, the
vitamin E,
the type of vitamin D, type of meat that you eat. All this thing might have an effect on the prevention, but once the cancer is there, I mean, it's not going to regress because you stop eating your steak, and or because you start taking vitamin, all the mega vitamins that you want to. I mean, it has, and there are some charlatans, some doctors that are making money, fortune out of that, and that's really unconscionable.
Well, I think it's important to
This
realize.
is actually, this is, Amos, 2 seconds. This is, the reason I raised the question and I posed the question is because this is real. I didn't even know how the people, they have a strong belief in it, you know, and this is promoted by some church and also some doctors.
Yeah, but you have to, like I said, you have to control it. If you deny it, I think it's going to be more difficult, but you can control it. If you have it in your department, you have a psychologist there, the nutritionist there, and you have, you know, exercise and everything there. So you want to have access to all that, you have to go through the doctor, to the regular medicine, and then they will tell you, so you can have access to that, I mean, say, other part of your body that you need to take care of. But the important part is the treatment. And if you have, I'm not saying that we have the answer for all the patients. Some of them don't even want to come to us. But, you know, instead of fighting that thing, we took the approach to say, okay, maybe there is a benefit for exercise, especially in patients which are taking LHRH or things like that. Yes, they need to do exercise. So you take an approach that, you know, it's not totally what they want, but it's almost what they want. And they found it reassuring that they can have that in regular hospital, you know, but we are not doing holistic medicine as they understand it, but we are giving them something.
Okay. Dr. Amos Chow, you have something you wanted to say?
I was gonna say, you see, what happened with patients when they are faced with the terminal illness, they are believed that anything can help. It's difficult for us physicians to take it away from them. We need to take that into consideration and help them understand, A, what you're offering based on the value of proven scientific evidence for certain treatment, whether it's surgery, chemotherapy, or radiotherapy. By the same token, I'm not saying you embrace what they were doing, but help them understand the limitation to whatever they believe in. I believe this is like religion, to be certain. There are people who believe prayer itself is a cure to a lot of things. We physicians, some of us may believe in prayer, some of us may not, but nevertheless, we need to know human being, it's complicated, and then their mindset when they are faced with the terminal illness. And then more importantly, we need to realize with the internet, anything you believe in, you can find a lot of people a lot of literature, whatever so-called literature, whether it's good or bad literature, to actually make you believe that you're on the right track. So I think it's an uphill battle for physicians to realize all of the other forces that come into the human psyche when they are faced with a terminal illness.
Okay, I think we have reached the end of.
There is a question for.
There's one more question. One more question. That's okay. We still have maybe 2-3 minutes.
I see a question for Dr. Jean-Philippe. How do you ensure high level of immunization in children due to the lack of confidence in the safety of the vaccine among many mothers? How best to prepare parents before school opens? The question is for Dr. Jean-Philippe.
Jean-Philippe. Is he muted?
Yes, he's muted.
Yeah. Patrick, you hear the question?
Yes.
He's muted again.
Can you hear me? Okay.
Can you?
Yes.
Okay, great. Sorry about that. I didn't realize I was muted. So it's just great questions, difficult to answer, and I'm not sure I have the answer to that. Though I will just share some impression. I cannot guarantee that they are fully supported by existing evidence. And actually, I'm not sure that if there's existing evidence that can really tell you exactly what you should do, but a few things to consider. I think first of all, conduct really good clinical trials that are open, transparent, adhering to best practices, and then really transparent in the results. I think that's one. Then obviously you are going to have, you may have good or less than good data, but if there's good data, then I think part of the dissemination, there's good to sort of the PR aspects of it. So it needs something that needs to be paid attention to. Now there's a lot of literature on it, and I can't say that I have reviewed all or been very familiar with it, but some that I've reviewed, there's that looked at factors about vaccine hesitancy in mothers, and the recurrent theme is vaccine side effects and vaccine safety. So I think again, if to the extent that it is something that needs to be shared, and if it's safe, then that needs to be emphasized to the parent. And something that I found interesting is that there's one report found a high correlation between willingness to accept, for instance, influenza vaccine as well, so correlated with COVID vaccine. So the less hesitancy for influenza vaccine, then the less hesitancy for COVID-19 vaccine. This was not big sample size, so that may need to be confirmed in bigger studies. But if then you can already see some strategy, which I had mentioned briefly about COVID-19 vaccination that is merged with routine vaccination. Or if it's an annual, some people have discussed already sort of one shot that has flu and COVID-19 vaccine. But again, that's going to be the vaccine platform would be important here. So these are some of the elements that can offer. I apologize. I cannot offer a much more intelligent answer to that, but but that's probably what I can offer for now.
All right, thank you.
Dr. Jerome, there's a question from Dr. Manigat about the, is an abdominal perineal procedure obsolete? If I may answer that question?
Yes, absolutely.
Yes.
Sure. So it is not obsolete, but obviously the procedure carries significant morbidity and then significant alteration in quality of life. And namely, you have to have a permanent colostomy, and you can have disruption of the perineal innervation and other organs. And but we're trying to move away from it by using TNT, what they call total neoadjuvant therapy. And as I showed in the data, there's evidence that in 40% of the cases you might be able to do that, to avoid surgery altogether. And but the second benefit of the neoadjuvant therapy is that you might cause a shrinkage of the tumor, and where the sphincter was compromised, you might be able to sort of manage to gain some margin that you can do the resection and preserve the anal sphincter. Certainly, there's some limitations because the person to begin with has a weak sphincter. Preserving the sphincter is not of no use. You're better off having a colostomy, but certainly it's not obsolete. There are indications, but we try to, as much as possible, preserve the person's function and preserve the quality of life.
Thank you.
But APR remains the standard, against which you would compare any other therapy.
Mhm.
Okay, the last question is for Dr. Goose. What is the recommended schedule to have a PSA? Dr. Goose.
The recommended schedule, if the PSA is normal, is once a year.
Once
And yeah, and after the age of 70, 75, actually we pretty much stop PSA, quote unquote, screening, which the proper name is prostate cancer risk assessment. So there's an age limit to it. If you think your survival is less than 10 years, there's no reason to do it. But in a patient from 40 to, let's say, 75 or a year, lifetime expectancy of more than 10 years, it's a yearly exam.
It's a great question. And there is none? No more question? Okay, good. Now, I think I have to thank you guys for very significant session where we all learn from the different, specialists. Yeah. It's the end of the day, and believe me, I started at 4 o'clock in the morning. To make sure
we all thank you. We all thank you.
So what we're gonna do now, I would like to tell you that tomorrow you have to be there at 9 o'clock. When you're looking at the schedule, you have one physician that did not present today. She will be presenting tomorrow. She's a professor of medicine at Sinai, and she's going to talk about COVID and lung failures. So we have to switch to allow accommodation for everybody to talk. So at 9 o'clock tomorrow, I will be happy to see all of you here, and encourage your friends who didn't sign up yet, that the session of tomorrow is going to be, you're going to have a lot of very good presentation. We're going to have someone, there is one subject I wanted to tackle is Parkinson's disease. And we have someone from Colombia that will talk to that, about that. Neurosurgery is there. And then a lot of subject on medicine and also GI. And then we will finish the day with a big symposium on psychiatry, where the gentleman from NIH, Dr. Cadet, will be there to give us some new information. So I will see you again tomorrow. Be there at 9 o'clock. We start exactly at 9 to allow the schedule to move.
Thank you very much. And
can you tell
night.
everyone to use the same link, please, for tomorrow?
Yeah. Okay. Mrs. Bruno has mentioned to us that whatever links you have today, you can use it again tomorrow.
Okay. Thank you very much.
Thank you.